So, hi, it is the 15th, second to last lecture in this series. And the Teach Us Dr. Hirsch semester 1 is coming to a close. And so we've got two left here. Literally also, we've got two left here. We are going over psychological disorders in this week. And then next week, we're going over treatment. We're going to be basically talking about therapy, the history of therapy, stuff like different approaches and theoretical orientations. Does therapy work? What are the predictors of whether or not therapy is going to work? All that kind of stuff. Do you think, is it possible that all those telehealth therapy things you've been hearing about on every podcast you listen to, like what's the one, BetterHelp and stuff like that, do they actually work? We'll talk about that. But for now, we're going to get into psychological disorders. This is a difficult and heavy subject. So I'm going to do my best to handle this with tact and to be as respectful as I possibly can. This is probably a subject that has touched almost everyone, and it's certainly something that has very, very intimately integrated into my own life, and I'm sure we'll talk about that a little bit later. So what are we actually going to do? We're going to talk about mental illness through the ages. We're going to talk about different perspectives, different ways that mental illness and disordered cognition have been approached, understood, and treated. We're going to talk about how we actually diagnose people. What are some myths and what is the reality of diagnosing? And we're going to get into different types of disorders, go over some examples, as well as how they're treated. So this is going to be a very broad survey of a very complicated topic. And I'm going to, like I said, do my best to do this justice. And then we'll talk a bit in office hours. So what is a mental illness? I always like to define terms on the top end, right? But this one is actually really, really hard because there is no singular definition. There are several factors that can play in, and those also change over time. And it's like a big part of this is that what we define as mental illness or a disorder is bounded in culture and in history. So whether or not something is considered disordered is going to change over time as different norms shift and change. So how do we actually think about diagnostic criteria then? If we're trying to think what are the different factors that people do consider when they're talking about whether or not something is a mental illness? Well, we get into stuff like statistical rarity. Typically, if something is considered a mental illness or a disorder, it is something that is rare. It is not something that is commonly felt or experienced by many people. Typically, it is also something that results in some form of impairment. So for example, if someone experiences, let's say someone has very profound depression and they have a hard time getting out of bed, or they have an attention deficit disorder that makes it hard for them to focus. Maybe a person has positive schizophrenic symptoms or schizoaffective symptoms, and they hear voices that make it hard for them to determine what is and is not really happening around them. These are different levels of severity, but they're all some form of impairment. And that's typically going to be a criteria that really has to be met for something to be considered a diagnosable disorder. Societal disapproval is also going to factor in, and it's kind of related to statistical rarity as well. If a person is just kind of minding their own business and whatever is causing their impairment, even if it's rare, if it's not really disapproved of, it's not really going to be seen as a disorder. And we'll get into some of the ways that that plays into diagnostic criteria, because it turns out, even now, in modern day, there are some tremendous discrepancies in how certain disorders are diagnosed based on gender, because the symptoms are seen differently in men and in women. Now, a big part of this, a very, very big part of this, that I cannot stress enough, because it is a hugely important factor in how we think about the criteria of diagnostics. Also, thank you, Tom. It's subjective distress. It does not matter if the person is impaired if they do not believe that is actually causing them some level of distress. So let's go back to that. Go back to that earlier example. You've got a person who is very depressed. They really could check all the boxes for clinical depression. And it makes it hard for them to function. It's hard to get out of bed in the morning. And it doesn't bother them. They're fine living that way. In that case, it's hard to make an argument that that's necessarily going to fit the criteria of mental illness or disorder, because it's not really bothering the person. And so there are going to be some extreme examples we'll talk about later where a person might be a threat to themselves or to other people. But in the vast majority of diagnostic criteria, if a person doesn't think of it as a problem, or they don't necessarily want treatment, well, then we wouldn't consider that to be a form of a disorder or a mental illness. Now, so what causes these things? It's complicated. Like anything else in this course, like anything else in psychology, it is complicated. Anyone that tells you that there is a singular cause to anything or a simple solution is lying to you. We do know in some cases, depending on the disorder, there are a multitude of different factors that can be weighted more heavily. So for example, in schizophrenic patients, we know that there is usually a characteristically low frontal lobe activity. We have also talked about this in a couple of other cases. Remember when we talked about neurotransmitters, we talked about dopamine in particular, and we know that dopamine in its presence or absence in the brain is implicated in how different people might form different forms of disordered behavior. And it's implicated in anxiety, it's implicated in depression, like obviously schizophrenia as well. If you've ever seen the movie Awakenings, the drug that they use in that movie is L-Dopa. It's a synthetic form of dopamine that's being used to treat catatonic schizophrenic patients. So there's a lot going on there in the actual biochemical nature of the brain. But we also know that Down syndrome in other types of disorders do have a heavy genetic component, maybe a predominantly genetic component. So there's a bunch of different things that can happen at play. There's also what we're going to get into in the diathesis stress model. We know that certain other disorders are highly hereditary. ADD, ADHD, extremely hereditary. And we'll get to some fun stories about that. But even stuff like anxiety disorders, bipolar personality, schizophrenic disorders, these all fall into and having some kind of genetic component. We also know that there is a component of experience or learning. What is happening around people and how do we learn to react to our environment? Because sometimes we're going to learn things that are going to shift the way that we interact with our environments in ways that could meet diagnostic criteria, like example phobias. Let's just read from the text. You have a bad experience, you develop an aversion to something that is disproportionate, and that anxiety, that fear, it can become disordered if it's out of proportion to the original thing. And that's what we'll get into with phobias and what constitutes a phobia. So when we think about disorders, it's a very complicated factor. And the thing is, this can also be different for different people. So one person might meet the diagnostic criteria for clinical depression because they have a family history of let's say, a deficiency of dopamine in the brain that causes them to meet those criteria. Someone else might meet those same criteria, but not because of a genetic condition, but because of something that's happening in their environment. Maybe they've had the loss of a loved one or something like that. So the same endpoint and criteria can be reached by a multitude of different paths. And it's important when we're thinking about what is a disorder to not just think about the label, but to think about everything that leads up into that label. So this has not always been the case, though, because it turns out that people have been thinking and conjecturing about mental illnesses basically since mental illnesses existed. So for example, back in the Middle Ages, we had the demonic model, where mental illness was the result of demonic possession. Exorcisms are still used today in some cases, but in the Middle Ages, it was seen as a way of dealing with a disorder. If someone is hearing voices or having some form of other just general complication, well, it's obviously the result of a demon. Something they have been bewitched, have been possessed by a demon, and so on and so forth, and that is the cause of whatever is happening. And this led to things like the Salem witch trials. Obviously, it's still brought about in popular horror media as well, but it is unfortunately not the way that things work out. And it did not actually stick around for too long, because as we move into the Renaissance, we start to see the emergence of a medical model where mental illness is understood as a physical disorder. So here we come to the Renaissance. It's not demons, it's not possession, it's not someone has not been bewitched or hexed. This is an illness. It is a disease. It is something that can be cured. And that's the important component here. When you start to think about a medical model, there is a treatment that can be applied. However, in the Renaissance, that mostly meant ritual scarring or bloodletting, and it's not great. It's not great. But we are seeing progress here toward a more humane model of treatment. We have a medical model now. It's just the actual medication does not exist. This is also where we start to get into asylums, where people were pulled away, chained up, and left basically alone. It's a very sad history, and one that proceeded into even for several hundreds of years. And unsurprisingly, taking people that are experiencing these types of maybe a psychotic episode and then chaining them up in an asylum and holding them away for the rest of their lives doesn't help anything, and it often makes things worse. And this is where we get into the moral treatment model. So Philippe Pinel and Dorothea Dix pushed for a treatment that also considered the humanity of the patient. It is inhumane to lock someone away. It is inhumane to treat someone as if they are irredeemable or incurable. And so if there is going to be a treatment, it should be rooted in kindness and respect the dignity of the patient. So even now, going into the early 1800s, we don't see a more effective treatment. But we start to see the consideration kind of building on that medical model in the Renaissance, that it's not like these people are possessed or incurable. This is a sickness, this is a disease, it is something that can be understood and can be potentially cured, even if we don't know how to do it now. So Dorothea Dix is hugely responsible for the humanization of people that experience psychological disorders, and deserves a lot of credit for that work. But then, as you can probably guess, there is a breakthrough, particularly the development of chlorpromazine. Yes, I said it right the first time. In the 1950s, chlorpromazine becomes available. This is the very first psychiatric drug that can be used and has been shown in clinical trials to treat symptoms of a range of disorders. In fact, it's still used today and has been highly influential in how we think about the sort of treatment protocols. It's moderately effective, and particularly for people that have schizophrenia and a number of others, prescribed even now for a number of other conditions as well. And this led into deinstitutionalization. So here's the thing, and I want to put this in historical context as well, and I see that's happening in chat as well. Yes, exactly. Into the 1800s, it took until the 1800s to get to the idea that people that are experiencing disorders deserve dignity. And into the 1950s, we still had asylums. Keep in mind, we didn't have these treatments. We didn't have medication until the 1950s. So when we think about the history of mental illness, of disorders, of treatment, it's very much a contemporary issue and something that people need to think about. This isn't the far off history. Remember when we talked about the lobotomies and people using lobotomies for treatment? That was even going on in the past 100 years. Like, you got to think about this. These are contemporary and modern issues. Now, chlorpyramizine becomes available. It's moderately effective for treating the symptoms of schizophrenia. And schizophrenic patients made up a large portion of the people that were locked away in asylums. So this led to, again, deinstitutionalization. The number of hospitalized psychiatric patients plummets, and they go out into the world. And some people are treated, and it's all good, and they go home, and they go on to live their lives. But more often, they relapse. That's it. And it's like, you have people, maybe they can't afford their medication. Maybe they forget to take it. Maybe there's just a lack of follow-up with these people. And so you have these people who have symptoms, who require continual care. They get a temporary window here via chlorpromazine. They're brought up back into the world, and maybe they're fine for a while. Eventually they relapse, and then, well, where do they end up? The asylums have been shut down. They just end up homeless. And so we know that, schizophrenia, chronic depression, and a range of other issues, particularly very severe issues, are heavily misrepresented in the homeless population, in part because of this. Remember, this is happening in the 1950s. So again, contemporary issues, and like a lot of the popular imagery you see of homeless people that are having issues on the street, like it happens all the time in media, it happens all the time. You've probably seen it. This is part of that legacy of deinstitutionalization, coupled with the for-profit healthcare system that places profitability over making sure that people get the care that they need. So again, highly contemporary issues and important to think about, because this is, when we talk about mental illness, we're talking about people. We're not just talking about symptoms. There are people that are experiencing these. And so it's important to, again, keep that in and talk about these to be respectful and to respect the dignity of the people that we're talking about. And part of that is acknowledging this history. So what about today? How do we think about this? Well, there are a lot of common misconceptions that are contradicted by evidence when we talk about diagnostics and how people are treated. One of which is that psychiatric diagnosis is simply pigeonholing, and that's not true. In reality, psychiatrists acknowledge that every case is unique. Remember, even on the front end, we're talking about how the same diagnostic criteria can be met by any number of paths and any number of factors. There is a myth that psychiatric diagnoses are unreliable, which is not true. In some cases, it's a little bit lower, but in general, inter-rater reliability is pretty high. It's about 0.8 for most disorders. Now, what does that mean again? Let's talk about reliability. Here's a quick refresher. A reliability coefficient ranges from 0 to 1. At 0, there is no relationship whatsoever between the things. At 1, the Venn diagram is a circle. So having a inter-rater reliability coefficient of 0.8 means that one psychiatrist might talk to a person, and then they talk to a second person, and overwhelmingly they agree. So this is just not true. And it's like, in general, things like depression, anxiety, schizophrenia, phobias, and so on and so on and so on are pretty consistently diagnosed even across psychiatrists. There's a belief that maybe these are invalid categories, and that most diagnoses are just about prediction of response to treatment or performance on different tasks. That is not necessarily true as well, that like psychiatric diagnoses do actually allow us to predict response to treatment. So one point is to say, like, you're telling me that I have depression, but that doesn't mean anything. The label is meaningless. Well, we know, again, from looking at the aggregate statistics, that generally by being able to diagnose or find a diagnostic label for a person, we can predict, again, responses to treatment, potential medications and courses of action, and performance on different tasks, and so on and so forth. So these aren't just labels that are thrown around willy-nilly. They have some real diagnostic weight. There's also the belief that psychiatric diagnoses stigmatize people. That's a harder one to talk about. And it's like, is being labeled as having a disorder a self-fulfilling prophecy? So if I go and I see a psychiatrist and they tell me, Ricky, you meet all the criteria of an anxiety disorder. And if I internalize that and say, oh, I have an anxiety disorder, does that become a self-fulfilling prophecy? Does that itself create more anxiety and worsen my symptoms and so on and so forth? And that's a complicated question, because it gets into how people interpret their own diagnoses and diagnostic criteria and all that. So there's a lot to be said there. So how do we do this? What are the rules of diagnosing? Well, let me tell you about the DSM, the Diagnostics and Statistics Manual of Mental Disorders, the DSM, currently on its 5th iteration of the DSM-5. It is the guiding book for how you can diagnose any range of disorders. There's about 300 diagnostic categories in the DSM. And what's interesting about this, I went looking for it to see what's going on with DSM-6, because there was some talk about it when I was still in grad school. But it seems like the APA, or the American Psychological Association, is taking a patch notes approach. So they're going to be mostly looking for a 5.1, 5.2, 5.3 approach before there's a full title update with the DSM-6. And it encourages a wide view of mental health, taking a biopsychosocial approach, biological, psychological, sociological approach that also tries to acknowledge, although sometimes doesn't do the greatest job acknowledging cultural differences. So generally the way the DSM categories are going to work is that, let's say you look up let's see, what's one I haven't used yet? You look up bipolar personality disorder. You look up bipolar disorder, and you look at, and let's say there are 10 different traits under there. And it will say that if a person is able to hit 5 of these categories, then they can be diagnosed. So it tries to accommodate a range of different potentially contributing factors. Again, like you look at anxiety, you know, you might look at personal distress, statistical rarity, so on and so on and so on. And so it's a way of trying to, again, accommodate. It's like and acknowledge that there are unique factors in every case, while still trying to impose this categorical model. So yeah, and again, also trying to keep in mind cultural differences. You know, for example, piercings are looked at differently in different cultures. It's like in some areas and at some times they might be seen as a mark of maybe body dysmorphia, but in other cultures it's no big deal. It might be considered a cultural practice or religious practice. And so the DSM tries, and arguably sometimes fails, to accommodate these types of perspectives. So let's get over the criticisms, because I think anyone that is familiar with the DSM probably has their own bunch. But let's be honest. 300 plus diagnoses, some of them are questionable. Like if you want to look it up, there's a diagnostic criteria for mathematics disorder that basically boils down to, are you bad at math? Are you clinically bad at math? So you might look at that and say, is that really, do we want to consider that to be a disorder? And even then, do we want to consider that its own disorder and not treat it as a learning disability or put it under a broader umbrella? So there's some issues that come into mind of like, where do we draw the line on where something deserves its own category? And some of these, again, are more subjective than empirical, and some can be highly comorbid. So back before I was a world famous, beloved by millions virtual YouTuber, I was a PI, or a principal investigator, in a psychological research lab, and we did clinical research. We mostly did sleep research. And one of the ways that we would actually look to validate our work, so just to make sure that people were actually being sincere when they were responding to questions and everything, is that we would look at the correlation between the anxiety and depression items, because those are incredibly highly correlated. So we call that a high comorbidity. One tends to come with the other. And so we knew as researchers that if those were not correlated in a data set, something had gone terribly wrong. And there's a criticism there then with the DSM. Again, where do you draw the line? If you're saying that, hey, you know, people that have anxiety are also extremely likely to experience depression, at what point do you stop and say that these are kind of two factors that are under a bigger umbrella? I don't know. Maybe in 5.5, we'll see that revisited. And a lot of these problems are really rooted in the fact that the DSM imposes a categorical model. People fit into boxes based on, it tries to make them broad, it tries to accommodate them, but fundamentally it's imposing a categorical model on what we would call dimensional factors, or things that tend to not be yes or no, but tend to have shades of gray. And so that leads to, again, a lot of gray area. And so there is an argument to be made that the DSM is kind of starting from a faulty premise, and trying to accommodate that premise and trying to get it to fit is never really going to work out, because it's just at square one, it was going to be impossible. So these are the concerns and the criticisms that are typically leveraged against the DSM. However, again, DSM criteria tend to be predictive. They predict treatment courses, they predict how people might respond to different scenarios, and so we know they're still valid. And trying to navigate and make the categorical model work and be more accommodating is an ongoing project throughout the history of the DSM. There is also a element of it's trying to medicalize what is and is not normal, because these are, again, diagnostic, they're medical labels. So if someone is experiencing major depressive symptoms following the death of a spouse, at what point do you say that is and isn't normal? When does it become a disorder? By having a categorical model like this, it's a yes-no question. There is a point that someone crosses where it's just, yeah, this is a problematic or a level of this symptomology. And so when is that necessarily appropriate, and when does it become clinical? Well, that's what a psychiatrist has to figure out, and it's a difficult question. With a long history of relationship to the law, we know that mental illness, people that are experiencing symptoms are not violent. This is one of the things that drives me crazy, because whenever I try to watch shows, even for entertainment, like Mindhunter or Criminal Minds or anything like that, I hate this representation, because it always feels like it boils down to this, that people that are experiencing mental illness have might be more prone to either more extreme violence or are more violent, and I can't stand it. But the vast majority of people are nonviolent. And even those that have very severe disorders, schizophrenia, for example, are, again, not necessarily violent. And in fact, it's the opposite. People that have, especially more extreme cases of mental illness, are actually more likely to be targets for violence than to be perpetrators of violence. However, criminal commitment is very much like the asylum process. And so putting someone in jail, and also it doesn't necessarily help them. And so we know that involuntarily committing people, putting someone in an institution, or if someone does have their mental illness leveraged against them and they end up being incarcerated, well, it's not going to help. We know this, and yet it still happens. I mean, the classic Foucault line, everything is prison, definitely applies to mental health and how we think about commitment and confinement. Now, there are some extreme examples. In cases where a person poses a threat to themselves or others, or they cannot care for themselves, a person might be involuntarily committed for treatment. So in the case, if maybe, again, somebody is so depressed that they are not eating and they are going to starve, that might be a case where involuntary commitment might come into play. Same can be true of, again, anything where someone is threatening violence either towards himself or another person. In those cases, then things like the Baker Act might come into play to involuntarily commit that person. All right. So now we're going to get into the specifics of different disorders. And this is going to be mostly going through kind of a laundry list. And we're going to start with anxiety disorders. So we've talked about anxiety a lot leading up to this point. We've talked about activation. We've talked about the parasympathetic and the sympathetic nervous systems. And throughout all those conversations, we've seen, even especially through stuff like the Yerkes-Dodson law, where there's an optimal level of arousal for a task, anxiety can actually be adaptive. It's actually, there are situations that we tend to encounter where not being anxious might actually be worse for us or more abnormal than being anxious. But it becomes problematic when anxiety spirals out of control. Interestingly enough, when it comes to diagnostic criteria, this is one of the earliest ones that we're going to talk about. The anxiety disorders can be diagnosed as early as 11 years old, before a person has even entered or gone through puberty. And generally, this is uncharacteristically young to be talking about diagnostic criteria. And part of the reason is that these symptoms, again, can manifest very early. And one of the biggest categories here is generalized anxiety disorder, which just refers to a constant, non-specific feeling of anxiety. So again, anxiety can be normal. It can be beneficial. If you're studying for the big exam, you got a big test, you got a big stream, you got a big presentation at work, it is normal to be anxious. In fact, that added level of awareness, of vigilance, and all that can actually come into play and be beneficial. It can get you to focus a little bit more. There's a lot that can go on there. The problem is that when you start getting into this point where your anxiety is out of control, it's interfering with your daily life, it is irrational. It's not even rooted in anything. When we talk about GAD, or Generalized Anxiety Disorder, one of the key characteristics is that you're just on. You're just on all the time at some unnecessary level of alertness. There doesn't have to be anything going on. There doesn't have to be a test tomorrow. There doesn't have to be a big stream, a big event, or what have you. You're just always a little bit more activated, or a lot of bit more activated than you should be based on the situation, which is what we mean when we say something is chronic. It's just ongoing and long term. You can really think about anxiety as kind of like glasses with different levels of water in them. Everyone's got their own their baseline. And for some people, that's very low. For some people, it's more in the middle. For some people, it's very high. And you deviate You go maybe go a little bit higher or a little bit lower than that, but generally you stay around the same point. For people that have anxiety disorders, particularly stuff like generalized anxiety disorder, they look more like the glass on the right there. You're just kind of always near that point where small disruptions can cause large amounts of impairment. And it's, oh, wait, let's see, we got a question here. What's the difference between generalized anxiety disorder and the free anxiety you get with packaged in with depression? So the comorbidity of anxiety and depression, we'll talk about a little bit more when we get to the depression section. The difference here is, again, and this is, again, it gets back to that idea of comorbidity. There really isn't a clear-cut line, because generalized anxiety disorder is just one diagnostic criteria, and people can fall under multiple branches. And so someone might be diagnosed with depression, but they're also very likely to get diagnosed with generalized anxiety disorder at the same time, because they tend to co-occur so often. So yeah, looking at, again, this metaphor, I always loved it. Like, it blew my mind the first time I saw it, because it was just so basic. It was so simple. But as a person who has at points in her life been diagnosed with generalized anxiety disorder, it's how it feels. That it's just kind of my resting point with anxiety is just higher than other people's. And so when something goes wrong or a situation comes up, it doesn't take as much to get me frazzled, because I'm already most of the way there most of the time. But with a combination of, some people will go medical routes, some people are able to regulate their anxiety by working through therapy. We'll talk about that a little bit in the next week, but we're going to be going along with this, and so we're going to see that there is also a multitude of treatment options. Now, panic disorders are a more specific application of an anxiety disorder, and they are characterized by repeated, unexpected panic attacks, a nervous feeling that escalates into fear or even terror. And this can be due to a specific stimulus or something completely out of the blue. And it's also characterized by the 1-2 punch of these actual panic attacks, coupled with a persistent concern about future attacks, and trying to make major changes in your behavior to avoid them. So it's not enough that you're just having the attacks themselves. There's also an added level where knowing that you could have an attack becomes a source of anxiety in and of itself, where you might just be sitting there like, I get panic attacks sometimes, and so you're vigilant and you're more activated because you're concerned about the possibility of a future attack. And you might avoid putting yourself in situations that could potentially trigger an attack and thus cause a change in your behavior, which might fall under impairment. Take a little sippy there. Phobias are an even more specific application of this anxiety model, which is an intense fear that is characteristically out of proportion to the actual threat. And this is the most common form of anxiety disorder. About 11% of people can meet the diagnostic criteria for a phobia. And it comes in a range of different forms. Stuff like agoraphobia, the fear of being in situations in which escape is difficult or embarrassing, or more specific phobias like social phobia, where you might have extreme forms of stage fright, or performance anxiety around signing a check in front of someone, for example, or getting up and streaming a psychological lecture. These all would fall under the same general banner of a phobia. And there are a lot of phobias out there. So let's bounce over here for a little bit. Whoop. All right. So we've got a major category of phobias that we can look at, like whether it's something in the environment, it's medical treatment, maybe it's a situation, maybe it's an animal. But there's a huge range of different ways that people can develop an irrational fear. The fear of flowers, the fear of men, the fear of pain, a fear of imperfection, fear of failure, fear of amphibians, fear of books, fear of being ridiculed, fear of clowns, fear of dogs, fear of houses, so on and so on and so on. Some of these might seem odd or might seem strange, but they are diagnostic criteria. People can develop these out of proportion responses to what otherwise might feel like benign or maybe even, just harmless things. Fear of water, a fear of long words. Let's actually see. Got a question. Is there a fear of ketchup? There is not a fear of ketchup. Is there a fear of deer? There is not a fear of deer in the list. All right. And there are a number of different ways to potentially treat an anxiety disorder. Some people might ascribe to exposure therapy. So I've used this anecdote before. Now, I, as a kid, did an overnight sleepover in Chicago's Field Museum, and just so happened I had to use the bathroom at night. I went wandering through the halls. For some reason, didn't turn on my flashlight. I got lost, and by the time I decided to turn my flashlight on, I was standing in front of the big taxidermy bear exhibit, and I was terrified. And now, even to this day, I get anxious when I'm in that museum and I come near that exhibit because I've had that experience. However, by going through and working through that and exposing myself to this exhibit, walking through it, reminding myself that the response is irrational and out of proportion, I've been able to work through that. And this is kind of the core of what we would call exposure therapy, where people will go through and work along to give themselves an impression or gradually work their way up to confronting the disproportionality of their response as a way of getting over the phobia. Now, there's also post-traumatic stress disorder. We hear a lot about this in media. It's highly sensationalized. There's a lot of misinformation that floats around about it. PTSD is an emotional disturbance following a severely stressful event, which can occur in flashbacks and recurring dreams, trying to structure your life to avoid reminders of the trauma. It can lead to heightened physiological arousal. So combat veterans and fireworks is the classic example, but even people that have experienced abuse in a relationship might find themselves alarmed when reminded of their abuser, or having maybe flashbacks or recurring dreams about the abuse that they had experienced. So even though we talk, like the common example is combat veterans and loud noises, PTSD can come from a range of different factors and traumatic events. The first time I experienced someone with PTSD, I was in high school, and I had a math teacher who had served in Vietnam. And one day, a car backfired in the parking lot while he was teaching, and he dove and ducked and covered under his desk mid-lecture. It was just a thing he did, and classes were canceled for the rest of the day. It's this kind of stuff. It lingers with people decades, and maybe even a lifetime after the event. And thankfully, with treatment, both in some cases maybe medical treatment, but also you're going through therapy, so like cognitive behavioral therapy, the stuff we'll talk about next week, it's possible to address these traumas. Now, obsessive compulsive disorder also has a lot, let's say, just like very banal misinformation around it. So people tend, I think, when I teach this, come with a lot of different presumptions about OCD. How often do you go on the internet and see people say like, I have OCD, ha ha ha, like it's kind of a joke, but it's a real debilitating disorder that is characterized by obsessions, the obsessive part of it, a persistent urge or thought or impulse. These can be inappropriate, like sex or aggression, and cause distress. So basically, on the front end, you have the obsession, a recurring intrusive thought, a persistent urge or impulse that just keeps happening. And then, in order to alleviate the distress from the obsession, the compulsion must also occur, which is a repetitive behavior that's, again, performed to reduce stress. So it's not when your cables are untidy or you're frustrated because something is out of order on your bookshelf. It's when you have this combination of intrusive thoughts that cause distress that then you might have to do these compulsions in order to alleviate that stress. Now, in even some cases, the compulsion is not related to the obsession, but might be learned over time. That maybe in a point where a person might have some form of, let's say you have an obsession where sometimes, again, you have intrusive, aggressive thoughts, and you don't like them, and they make you feel bad, you're distressed, but you learned one day while you were having an obsessive fixation that snapping your fingers distracted you and reduced your stress. And so the compulsion isn't necessarily related. It's just something that is somehow been connected. see, got a question. Is there an overlap between compulsions and tics? I actually don't know. I'd have to look it up. My gut response is probably not, because the compulsion is something that is engaged as a form of reducing stress, and I don't think that also applies to tics. But I do have a fun media example. So let's bounce back over to the other window. So this is a video that I usually show people. It's a short one. It's kind of dramatized, but I think it hits at some key points. So let's get on those closed captions and take a couple minutes to check it out.
3, 4, 5, 6. How long did I sleep for? I got to bed at 3. Let's see, 3 o'clock.
Also increase the volume.
I hope I didn't do anything stupid yesterday. 3, 4, 5, 6, 7. How many hours did I sleep? How many hours did I sleep? How long did I sleep for? 3 a.m. 2, 3, 4, 5, 6, 7. I'm feeling lightheaded. My heart's feeling a little lightheaded. I'm feeling lightheaded. I don't feel good. My heart's beating. I don't know if I feel all right. I think I feel all right. I'm okay. Yeah, I feel all right. No, I feel fine. I don't know if I should take my meds. I should take my meds. Should I take my meds today? The medicine's working. It's gonna work. The medicine's working. I should stay on the medicine. How do I know if the medicine's working? I don't know. Should I take meds today? How many hours did I sleep last night? I didn't get enough sleep. 2, 3. My pulse is low. 4, 5, 6, 7, 8. Pulse is fast. Pulse too fast or too slow? Can you pulse be too slow? 10, 14, 15, 11. What happens when your pulse is too slow? 13. My appetite really isn't there. I hope it's okay. I don't really have an appetite. My appetite's not great right now. Why? Am I sick? I'm sick. You're not sick. You're fine. Maybe I'm too hungry. I shouldn't be this hungry. Oh God, I'm too hungry. It could be my thyroid. That's why I'm so hungry. Could be my heart. My heart is my thyroid. You know what? I'm gonna write. I'm gonna go write. 4, 2, 3. Looking forward to writing today. 7, 8, 9, 10, 11, 7, 13, 14, 15, 16, 17. I'm looking forward to writing today. I can't wait to write today. It's coming. It's flowing. I'm writing very well. I like this story. I'm gonna write a lot. I'm gonna write so much today. I'm loving this. This is great. My stomach hurts. My stomach's really hurting right now. My stomach's really hurting right now. I hope it's not Ebola. What if it's Ebola? I was on a plane recently. I hope it's not Ebola. Oh God, I need to look up the symptoms. Right now, it could be Ebola. Don't look up the symptoms. Don't look up the symptoms. I need to look up the symptoms. Do I have Ebola? What's going on? I need to take my temperature. First, it's thermometer. You're my temperature. You're fine. Okay. I can't tell if I'm hot or not. Am I fever? Over 100. If it's over 100, that's not good. If it's over 100, I'm going to the emergency room. Okay. What's my pulse? What's my blood? Check my blood pressure right now. I think I'm fine. I think I'm sick. My blood pressure's high. My blood pressure feels high. My blood pressure feels really high. I'm freaking out. I'm freaking out. I'm freaking out. I need to smoke. I'm gonna just have a smoke. Just have a smoke. You'll be fine. I read cigarettes are good for your intestines, actually. Why am I smoking? I hope I don't get cancer. Why am I doing this? Why am I doing this? Why am I doing this? This is a heart attack. This is a heart attack. My heart is racing right now. My heart is racing. My heart is racing. Okay, this is a heart attack. This is a heart attack. I'm having a heart attack. Take a deep enough breath. I feel like I'm gonna pass out. I need to sit down. I need to just go over here and sit down. I can't breathe. Smoking increases your heart rate. I gotta just sit down. Smoking kills you. Smoking is killing me. Why would I do this? Smoking is killing me. This is ridiculous. Okay. Relax. You got this. Meditate. Remember meditation. Remember the breath. Focus on the breath. It's just anxiety. Nothing ever happens. It's just anxiety. You'll be fine. Nothing ever happens. It's just anxiety. Remember the breath. In. Out. You're okay. See, you're fine. In. Out. See, you're okay. I hope I got enough sleep last night.
So we can see through there, again, it's dramatized, but it gets the key points. What we see is the intrusive thoughts, particularly in this case, it's about health and whether or not the person is sick. And they keep going back and forth. Am I sick? Did I sleep enough? What about my blood pressure? What are my symptoms? And going through all of this, and we see the counting and other behaviors that they have kind of worked in to try to help with that anxiety, taking their temperature, taking their blood pressure. These are what we would consider to be compulsions. Being like specific behaviors that they have gone through to try to alleviate and bring their anxiety back down, following these consistent and persistent thoughts or impulses. And again, in this case, being that they're sick. Am I sick? Am I getting sick? I was on a plane recently. Did I get sick from that? And even when they're sitting down and working in the video, it comes back. They're focusing on writing. They're having a good time writing. And all of a sudden it's like, oh my God, what if I'm sick? Now I have to stop doing this and I have to go take my blood pressure. I have to go take my temperature. I have to engage in these compulsions, these repetitive behaviors to bring that stress back down because, well, without it, it's difficult to function. So where does anxiety come from, especially when we're talking about disordered anxiety? Well, there's a couple of different ways to think about this. So learning models would say that these are connections in our brains that are made by classical conditioning that are then maintained by operant conditioning. So somewhere along the line, a person developed a classically conditioned response of elevated anxiety to a particular stimuli. And then in the case of something like OCD, engaging in the repetitive behavior gets reinforced by operant conditioning because it reduces anxiety. Now, another way of approaching this then is to use exposure therapy, which I alluded to earlier, where you can learn your fears. And it's like, if you can learn fears from other people, you can also go through different experiences to unlearn those as well. It's probably the best use of virtual reality. So actually in clinical contexts, people will have, especially people that have phobias, let's say of heights, will come into a therapist's office and actually use a VR headset to simulate exposure to whatever the cause of their stress is, to decouple whatever that association is in their brain that is causing that increase of anxiety. There are a couple other things that we know. Anxious people tend to think about the world differently, particularly in terms of catastrophic thinking, of believing that terrible events that are going to happen despite a low likelihood of happening. There's also a reality that some people are maybe just more susceptible to anxiety to begin with. And so you have in having an anxiety about anxiety, basically. In that case, we see standing up too fast. Things that might be banal to other people or just very normal might be a source of anxiety in certain people that have a form of this sort of sensitivity. And we also know that it has a connection to personality. Specifically, neuroticism, one of the big 5 traits that we talked about last week, which has a genetic component. So people that tend to be neurotic tend to also be anxious, and this is also implicated in depression. And people that are high in neuroticism tend to have kids that are high in neuroticism. So there's a genetic component here. So we have sort of the multifaceted way that we can look at anxiety disorders. You've got one outcome, a disordered anxiety that can be caused by a combination of environmental learning, genetics, and so on and so forth. So it's, again, it's the same endpoint, but can be reached by a multitude of different paths. So let's talk about mood disorders. This is going to be the next major point that we talk about. So about 20% of Americans experience a mood disorder at some point in their lives. About 16% overall experience what we would call major depressive disorder at some point. In general, it's more likely to be diagnosed in women. Why not? Why? Well, it's a complicated factor. There may be differences in social expectations and economic standings, but there also might be differential diagnostic factors that the same symptoms might be judged differently in a man than they would be in a woman. So, for example, if a man is saying, I'm sad, I'm having these issues and difficulty to function, that man might be told to deal with it, rub some dirt in it, and all with the toxic masculinity, whereas a woman might be seen as, again, more easily categorized as being depressed. Depression is complicated. I mean, there's a lot of different ways to talk about it. It can happen suddenly. It can develop gradually. In general, people that experience depression, is a clinical depression, experience episodes where maybe for 6 months or a year, they might experience an extreme functional impairment. And these tend to be recurring, where it's like maybe you have 6 months where you're showing those symptoms, and then maybe you're fine for a while, and then it comes back at some point. So major depressive disorders are in some ways complicated to treat because, again, they can have a multitude of causes, and they can be temporary, they can be chronic. And their causes tend to be a blend of biological, psychological, and social influences. And depression tends to lead to a loss of social, if you get depressed, if you withdraw, you lose social support and connection to social resources that can beget deeper depression. So it can also, through the specifics of how depression tends to impair people, sort of propagate and worsen itself. You're depressed and you don't necessarily care and you stop really taking care of yourself and you aren't taking your medication, well, then if you're taking your antidepressants, your depression is probably going to worsen. And there are a number of different ways that we have thought about depression over the years, one of which is Cohen's social model, which personally I don't love, but I have to talk about, which is that depressed people tend to seek excessive reassurance. I think this honestly sucks. And basically saying that people, like, while talking to depressed patients, like undergrads in a study that, like in this model, found the depressed people were seeking reassurance, and then that tended to put the participants or the undergraduates that were talking to them off. I hate this, honestly. I think it sucks. And it's like to try to say, like, you know, depressed people they just want to be told that everything's okay. And then people just like, they're basically saying depressed people are needy. And then other people are turned off by that. It sucks. There are also, unsurprisingly, behavioral models of depression, when saying that depression is caused by a lack of reinforcers in a person's environment. Now, Beck's cognitive model tends to, again, if we want to break this back in, we have behaviorism, then we lead into the cognitive revolution, and then Beck comes along and responds to these behaviorist implications and models of depression by saying that, no, we have to also consider thoughts and beliefs. Depression can be caused by negative beliefs and expectations. So having negative views of the self, of the world, and the future can lead to distorted thinking that can contribute to depressive symptomology. I've talked about this one before, but I want to revisit this in the context of depression and learned helplessness. So one thought in this cognitive model is that one of the contributors of depression is that people have an expectation or a perception that they can't actually change their situation. We call this learned helplessness, and it was discovered by two grad students who were doing experiments in learning. So what they would do is they would take the dogs in their lab and they would set them up in this box. And the thought was they shock the floor or electrify the floor on the side of the box that the dog is on. And then the dog will jump to the other side, to the floor where it's not electrified. The thought was that eventually, by pairing the shock with the sound, they could teach the dog to jump over the hurdle. I hate this. Again, like, I'm just going to give my personal feeling here. This was unnecessarily cruel because they didn't know about learned helplessness. Learned helplessness was a happy accident of their decision to say, well, what would happen if the dog couldn't escape the situation? What if there was no hurdle? What if we just kept shocking the dog? What would it do? What they found is if the dog was unable to escape the situation, if either they removed the hurdle and replaced it with a wall, or both sides of the floor were electrified, eventually the dog would stop trying to escape the situation and would just lay down and deal with it. It's monstrous, and like it makes me angry. Like, this is a thing that most people don't talk about when they talk about learned helplessness. They don't want to get into the specifics of, like, two incredibly cruel grad students tortured an animal to discover this, but it's the reality of it. It pisses me off. But anyway, the way this is implicated then into depression is that we'd eventually, maybe through conditional learning, develop a perception that we cannot change our circumstances, and that we also might start to internalize negativity while externalizing positive attributions. This is the exact opposite of the self-serving bias, which in the social psych chapter, I mentioned how the self-serving bias is flipped around for people that have symptoms of clinical depression. So there's a way that our cognitions tend to reinforce the symptomology of depression. So if you're having symptoms, you feel shitty, you start to believe that you can't do anything to change your situation, you start to internalize negative events and explain away positive things, well, it tends to become a very, like, what some would call a depressive spiral. When it comes to causes, we know that genes likely play a role, and there is some implication of dopamine, but depression is complicated. It's like anything else, and there's a range of cognitive and social and psychological and genetic factors at play. Like, who develops depression, how long do their episodes last, and so on and so forth. Now, bipolar disorder is the next mood disorder we're going to talk about here, which is characterized by a combination of depressive and manic episodes. A person, instead of having monopolar depression, they might have manic spells where they experience elevated mood, a lower need for sleep, high energy, talkativeness, inflated self-esteem, and it also tends to lead to highly irresponsible and risky behavior. Again, this is also highly genetically influenced. About 60 to 85% of people that are diagnosed with bipolar disorder have parents that have been diagnosed with bipolar disorder. But it can be triggered by stressful life events, both positive and negative. So there's a combination of factors here. Even if you have parents who might have developed bipolar disorder and might have shown symptoms of it, it might take a catalyzing event in your own life to bring those symptoms out in yourself. So this is where we get into, again, some complicated factors here. Now, one way that bipolar disorder is treated is with lithium. So if you've ever heard the Nirvana song Lithium, probably brought about by treatment for bipolar disorder. But the thing is, people that are bipolar sometimes like the manic episodes. They like the elevated mood, the talkativeness, the inflated sense of self-esteem. And so it's actually sometimes difficult to treat because people that are prescribed lithium to regulate their mood might miss those manic phases and stop taking their lithium. Whenever I have talked about clinicians that have dealt with bipolar patients, they say that it's a pretty significant problem, or it's something that most people have encountered at some level, where it's just that this is a difficult point to treat. Monopolar depression, most people don't want to be depressed, but when it's also connected to these manic episodes that can feel very good, it becomes a more complicated matter and comes back to that all-important segment right at the front about subjective distress. If a person doesn't necessarily see themselves as being impaired, they don't see themselves as being disturbed or bothered by the symptomology, it becomes difficult to label them with a disorder. It becomes a more complicated matter. Moving into suicide, major depression and bipolar disorder do place people at a higher risk for suicide than most other disorders. Every year in the US alone, about 30,000 people choose to commit suicide. There were a number of different risk factors, mostly feelings of hopelessness, depressive symptomology, a history of previous suicide attempts. And for most people, suicidal ideation tends to exist for a short period of time, although it is often reoccurring. And so for the people that do develop at some point either passive or active suicidal ideation, it tends to pass over time, although it can be reoccurring, emphasizing the need for consistent treatment, whether that's medical or therapy, etc. There are a number of very common myths, some of which I want to drill down here, about suicide. One of which is that talking to a person with depression about suicide might make them more likely to commit the act. The reality is that studies have shown that is actually makes people less likely to commit suicide and more likely to obtain help. And so some of these things that get passed around in media, like, oh no, you shouldn't talk to them about suicide because it might give them the idea. No, it doesn't work out that way. Generally, when people that are experiencing those symptoms, and might even be at some phase of suicidal ideation, when they talk about it with another person, that tends to motivate them to go seek help. There's also this belief that some people might be, they're faking it. They're talking about it for attention. That's all they want, but actually, people that are talking about suicidal feelings or suicidal ideation tend to be considering it. And talking about suicide is associated with a considerably greater risk of actually going through with a suicide attempt. So there's a number of different factors that go along here, because suicide, like many of the things that we've talked about already, has a lot of common myths and anecdotal experiences wrapped up with it. But in this case, many of them actually make things worse, and it's important to talk about and correct them. So getting into let's get into personality. Personality disorders are tricky to diagnose because like we've talked about personality. All right, let's see. I have a question here. Regarding people talking about suicide, does that include the ha 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 funny nihilism where people joke about committing suicide? Typically, yeah. There's always, what's the old saying? There's always a kernel of truth in any joke. For people that talk about this or even make jokes about suicidal ideation, there's maybe something there. It's always worth taking seriously. Yeah, it's that the joke is that it's not a joke. I did a study. Here's a fun social psych anecdote. I did a study a while back where I worked with another faculty member, and we took the worst racist jokes you have ever seen. Like, they were awful. They were groan-inducing. It's the kind of shit you would hear Rush Limbaugh say. But we asked people to read those jokes and to rate how funny they were. And then we asked them about their opinions of the groups that were being made the butt of the joke. And lo and behold, these jokes that are just on face not funny. No one thought they were funny. But people that, let's say, if it's at the expense of African Americans, the expense of Hispanic people, that tended to predict that the people that found the joke funnier had less than great opinions of those groups of people. So kind of the sum of the research is that, a joke is very rarely just a joke for most people. And in some cases, humor really is a window into the soul. So people that are able to joke about that and like, ha ha ha, and have the funny nihilism, it's maybe worth taking a little bit more seriously. At least, anecdotally, pulling for like teachers' own life experience, at times where I've made jokes like that, I've been at pretty low points and trying to laugh it off. In some cases, I've maybe been passively suicidal at junctions in my life. And those are also typically the junctions where I would make jokes like that. So it's just, I think it's always worth taking seriously. This is something I think about a lot. I've lost friends to suicide, and I think about them a lot. It's something that it hits me really deep. All right. Personality disorders. Oh, I'm getting emotional. Oh, wow. I'm actually crying. I have a class to do. That'll come later. So personality disorders. Personality traits that tend to fall under characteristic disorders they tend to appear by adolescence and tend to be stable as well. Remember, we've talked about personalities being very flexible. It tends to be very malleable. Personality disorders, the traits that tend to get somebody into a diagnostic category, also tend to be things that tend to be consistent over time. And that consistency is part of what is really a critical part of this, part of the core of the diagnostic criteria. And there is a substantial comorbidity with mood disorders and anxiety disorders. So borderline personality disorder, characterized by an instability in mood, identity, impulse control, or self-destructive tendencies, tends to fall under this umbrella. It's more prevalent in women, and it's like with about 2 to 6% of the entire adult population having been diagnosed. Now, this again tends to fall under a social biological model. People tend to overreact to stress. It's like they tend to have difficulty regulating their emotions, and those people would also come into, might be people that you would consider as potentially having borderline personality disorder. Psychopathic personality disorder is an interesting beast. Again, this is something that people believe exists, but doesn't actually exist in the DSM-5. So in the modern conception of diagnostic criteria, there is no such thing as a psychopathic personality. It just doesn't exist. Informally, there's a lot of research about it. People might be called sociopaths or psychopaths, but it doesn't exist as its own category. The research that does exist characterizes it as being marked by superficial charm, dishonesty, manipulativeness, self-centeredness, and sometimes risk-taking. It tends to overlap with antisocial personality disorder, which is actually a diagnostic criteria that tends to be predominantly diagnosed in men, but still only places people at a somewhat heightened risk for crime or violence. So whenever you see people talk about, oh, they have a psychopathic personality in a crime drama or something like that, it straight up doesn't exist. It's a popular conception, and that conception has driven research that has kind of given sort of this parallel sort of not even diagnostic criteria, but this parallel conversation to the actual diagnostic criteria of the DSM. So what causes someone to develop a psychopathic personality? Most people, we have really very little understanding. Some research shows that maybe it's a deficit in fear, or what we would call stimulus hunger. That people that tend to develop psychopathic personality, or what we would call psychopathic personality conventionally, tend to be chronically understimulated. And so, unlike someone who has an anxiety disorder, where their cup is mostly full, this person is problematically low in anxiety. And so, the lying, the manipulativeness, and all of that is about seeking thrills, seeking stimulation. And this tends to come up in the research that does exist around even serial killers and serial offenders. This tends to be a consistent theme that comes up, the chronic underarousal. And so transgressing, whether it's through consistent crime or murder or anything like that, is really about seeking thrills and stimulation in a person that is chronically understimulated. Right, moving on from personality into dissociative disorders. A dissociative disorder is characterized by a disruption in consciousness, memory, identity, or perception. So people that tend to have experiences of depersonalization or derealization, feeling like they're outside of their body, would tend to be showing symptoms of a dissociative disorder. Now, one of the more interesting examples is dissociative amnesia, where there are large gaps in a person's memory due to a traumatic experience. So there are cases where trauma can be so intense that it causes a person to repress it to such an extent that they disassociate. It's just not something they necessarily remember. And so then through that disassociation, they're able to manage that trauma. And the research connects that then to, broken clock right twice a day, Freud's conception of repression. Dissociative fugue is an interesting point where you build on that idea of amnesia coupled with fleeing a stressful situation. So there are people that will pick up one day, maybe in response to the death of a partner or an extreme stressor in their lives, and they will peace. They will disappear, pick up, and then maybe be recognized by somebody 10 plus years later, living a completely different life. And they have no memory of it. It's a dissociative fugue state. You flee the situation, have no memory of the events leading up to it, and then eventually pick up and keep going somewhere else. It's rare, but it happens, and there's a couple of very interesting case studies that have been written based on it. Dissociative Identity Disorder, or DID, is the most famous and most controversial form of a dissociative disorder. It's marked by having two or more distinct personalities, frequently called alters, within one person. And these can lead to differences in respiration, brainwaves, handedness, handwriting, any number of factors. It's like in the people that have dissociative identity disorder, or DID, it seems like there are multiple people living within one body. Although, in some cases, it's like under further scrutiny, this doesn't necessarily hold up. And some of these more extreme behaviors that people see, like shifts in handedness or handwriting, can be explained by voluntary actions on the behalf of the person. And typically, in empirical tests, information that is learned by one alter is accessible to all other alters. So there are different ways that we can try to understand this. This can be connected to repression. In some cases, maybe a person might experience a trauma so intense that they create a person to have, besides themselves, to have experienced it in order to manage that trauma. And there's also the reality that some people might not necessarily, might have suggestive or social influences. Not necessarily that they're faking, but that there's some sort of social pressure or something else going on in their lives that's leading them to develop these alters, like in the absence of extreme trauma. So this is very, very difficult to talk about, because again, it's one of these things that's very sensational. Most people have ideas about this as being a very, I wouldn't say common thing, but like being a more frequently occurring thing than it is. Under empirical tests, a lot of people that have dissociative identity disorder, it don't tend to hold up. There are very few cases where we would, under further scrutiny, the criteria of DID tends to carry on, and it's like, and withstand that scrutiny. So there are so many few cases, but the ones that are out there, like do actually have some pretty compelling research. It's a very interesting thing to get down on a rabbit hole. Schizophrenia, and it's like in schizophrenic disorders, tend to be severe disruptions of thought and emotion that can result in a loss of contact with reality. So disturbances in attention, thinking, language, emotion, relationships, including a range of positive and what we call negative symptoms. So when we think about schizophrenia, most people think about the positive symptoms. They think about hallucinations and delusions, but there are also negative symptoms. Disordered thinking, and in some cases loss of motor control, are also symptoms of schizophrenia that involve a loss of something or a negative symptom. It occurs in less than 1% of the population, but is represented in over 50% of people in mental institutions. So when we think about going back to asylums and the history of mental health and mental treatment, the story of asylums is very difficult to break away from the story of how schizophrenic patients have been treated and the symptoms and treatment of schizophrenia. So like I was referring to before, one of these sets of positive symptoms that people tend to be very familiar with is the delusions. Strong, fixed beliefs with no basis in reality, and we would consider this to be a psychotic symptom. Hallucinations go along with that as well, which are sensory perceptions in the absence of an external stimuli. Other things like disorganized speech and behavior are, like I said, negative symptoms because they relate to the loss of something, but these are generally sort of a different range of symptoms that tend to fall under schizophrenic disorders. In fact, there's many different subcategorizations of schizophrenia. Going back, if you've ever seen the movie Awakenings, which I've already referenced before, but I'm going to reference again, the patients in the movie are catatonic schizophrenics. So they don't have necessarily the delusions and the hallucinations, but instead they have in some cases, near total loss of motor control, causing them to fall into a catatonic state. So it's a good movie. It's worth checking out. I want to say it's a Robin Williams movie, actually, off the top of my head. We know that genetics predispose people to developing schizophrenic symptoms, but that's not necessarily the only thing. The Diathys stress model, which works here and works generally, posits that it's not just a genetic propensity. Going back to think about the cup with the water in it, different people have different levels of sort of preparedness to potentially develop different patterns of symptomology. And it might just take a life event to trigger that in a given person. So, for example, when we talked about depression in response to life events, people can hit the clinical criteria for a major depressive disorder, not necessarily because they have a consistent genetic predisposition, but rather that they had they were sort of part of the way there, and then their environment shifted in a way that caused them to develop more pronounced symptoms. There are early warning signs of schizophrenia, and stuff like thought and movement problems, a lack of emotion or flat affect, social withdrawal, etc. But again, this is sort of a very complicated set of disorders that can be triggered by genetics, can be in a combination of environment, and we know tends to have, again, like a very heavy genetic, a pretty heavy genetic component. Rounding out into the end here, so getting into autism spectrum disorders. Autistic disorder and Asperger's disorder, which is sort of a less extreme or less severe form of autism, tends to is again very complicated, and there's a huge amount of research on autism and a range of diagnostic categories under the label. But in general, if we're talking about autistic disorder, it tends to include a deficit in language, social bonding, imagination, and is sometimes accompanied by low IQ. So if you're looking in the DSM-5, it's typically what you're going to find when you're looking up autism. There has been an increase in prevalence of autism diagnoses since the early 1990s, likely because of a shift in relaxed diagnostic criteria. So this is an interesting piece because this is probably like one of the best modern examples of how a shift in diagnostic criteria can result in an increase in prevalence. By opening up the diagnostic categorization of autism, more kids are getting diagnosed with autism, leading to the illusion that there is an increase in the prevalence of autism for some other reason. You're probably aware of vaccine conspiracy theories in connections with autism, which is an illusionary correlation because vaccines tend to be administered around the same time that symptoms appear. But it turns out, let's see, I need to go actually bring this one up. So give me 1 second and I'll go grab it. The research that was conducted and first triggered this entire body of work in conspiracy has since been retracted. It doesn't stick around. We don't consider it to be valid research. However, the cultural notion still exists. So when we think about spurious correlations, I just want to revisit it because this is just a fun thing to look at. If you look at just the data, it does look like an increase in the number of vaccinations or in the timing of vaccinations with kids leads to an increase in autism in the aggregate. But correlation does not equal causation. US spending on science and technology is correlated with the number of suicides by hanging. The number of people who drown in a pool in a given year is correlated with the number of films by that Nicolas Cage appears in. Per capita cheese consumption is actually correlated quite well, actually, with the number of people who die by being strangled in their own bed sheets. You can go through all of this, and you can find any number of bizarre, illusory correlations. But in some cases, they're convincing because people want to believe them. In the case of autism spectrum disorders, parents don't want their kids to be autistic, and they're looking for something to blame. And so they find this research that tells them that it's not their kid, it's not anything that was out of their control. It was actually the vaccines the whole time. And it's hard to calculate the amount of harm that's been done by this vaccine conspiracy. This link with the MMR vaccine to autism has been repeatedly falsified. The original research has been retracted, but the cat's out of the bag. It's just in the zeitgeist now. And it's horrible, some of the things that people come up with. Desperate people will try a lot of pretty horrific things to try to treat their kids after they've been diagnosed with autism. Recently I was kind of plumbing around, listening to some podcasts, and a popular thing that seems to be prevalent with this variety of people looking for alternative medicine or alternative treatments after their kids have been diagnosed with autism. Yeah, you got it, Raina. It's giving your kids a bleach enema, causes them to shit out their own intestinal linings. And then these people are convinced that that's helping their kids, or forcing your kid to drink bleach because you're convinced via the internet and conspiracy theories that that's going to treat their autism. And of course, these are kids that in some cases are nonverbal, that they can't do anything about it. It's so upsetting. And I remember when I was first writing these slides, I was talking to my teaching supervisor in grad school, and she got red in the face angry as we were talking about this. And I'll be honest, if there is a hell, I think the researchers that propagated the autism vaccine link belong there. That's my personal editorializing there. There's something so horrific about this. And when we talked about earlier, people that tend to have disorders tend to be at much higher risk of being victims of violence. That's violence. That's violence right there. And it happens, and it's horrific. Anyway, moving on before I upset myself more. Let's talk about ADHD and ADD. So attention deficit hyperactivity disorder, well, it's characterized by a lot of different symptoms. Typically inattention, impulsivity, and hyperactivity are the three big ones that people think of. And it is diagnosable in about 3 to 7% of school children, but is more likely to be diagnosed in men than in women. Now, there's some interesting reasons for that, because it turns out that the behaviors that would otherwise get a man or a boy diagnosed with ADHD tend to be seen as goofy or quirky in women. It's like you don't have ADD, you don't have ADHD, you're just like, you're forgetful, you're airheaded, you're uncoordinated, you're clumsy. Those tend to be very gendered terms that actually contribute to the discrepancy between men and women and the diagnosing of ADHD. And it's implicated with numerous functional problems in children and adults, ranging from executive dysfunction to inattention, again, impulsivity, so on and so forth. And it is highly genetically influenced, but can be treated successfully with stimulant medication. So if you've ever heard of Adderall, usually if you've ever been to college, there were people selling Adderall on campus around finals. That was at least how it was when I was in school. The thing is, for people that have ADHD or ADD symptoms, taking Adderall, which is a stimulant that's chemically very similar to basically methamphetamine, it actually helps them focus. It helps them slow down, and it helps them stay fixated on a task. Whereas in other people, it has a very different effect. It's like the biochemistry that contributes to ADD and ADHD responds differently to stimulants, and in a way that can actually help improve a person's functioning. And we know this is highly genetically influenced. People that have some form of an attention disorder tend to have kids that have attention disorders. And there are a range of different ways that this can be treated. So on one hand, there's stimulants. There can also be behavioral ways of looking at this. Making lists, keeping to-do list trackers to keep you on track are also ways that people can help manage ADD and ADHD symptoms. So in a funny anecdote, I personally have had a really rough time in the past 2 years because I used to have a very good routine, and then COVID happened. And I lost my ability to keep that routine. And since then, I have noticed that my functioning has gotten worse over time. And eventually I started thinking about it, and I was like, you know what? I think I might have ADD or ADHD or something. And I remembered faintly that was a conversation when I was younger. So I called my mom up, and I was talking to her, and I said, hey, Mom, remember when I was seeing all those doctors as a kid, and there was that thought that maybe I have, that I might have ADD or ADHD? What do you think about that? So we went and we talked about my symptoms and what was going on, and the fact that it turns out I had actually been on Adderall at some point, and which I totally had forgotten. And then as I'm talking to my mom, she stops and she's like, I don't think you have ADD or ADHD. I do all those things too. And whenever I have problems, I just go drink a bunch of coffee, and it helps me. And in that moment, I became pretty sure that my mom probably has some form of an attention deficit disorder, and I probably do too, which is very difficult, and it's frustrating. It's I don't want to get too into the reads on it, but it's been very hard because getting a diagnosis and getting medication as an adult is hard, and it is expensive. Insurances in the US don't tend to cover ADD or ADHD screenings, meaning that it can be hundreds, if not into the thousands of dollars to go through the process to get access to medication. So the question here is is this different only with Adderall, or does it happen with other stimulants as well? Yeah, short answer is yes. And, this is a thing that I've come to recognize as well, that turns out my use of coffee in maybe use and abuse of caffeine over the course of my life might have been a form of self-medication without realizing it. It's complicated and very personal. This has been I actually, when making the slides and going back and revisiting this one, definitely upset myself a little bit. So one of the other bits that does coincide with ADD and ADHD that I mentioned before is executive dysfunction. And for the longest time, I've had such a difficult time trying to explain executive dysfunction to people. And then I found TikTok. And a friend sent me this TikTok, and it is incredible and knocks it out of the park in being able to actually explain what executive dysfunction is like. So let's give it a listen.
What is one thing that you do that us non-ADHD people need to know?
Oh my gosh, I'm so happy you asked this question. I actually have an example that I always use to try and explain executive dysfunction to people. Okay, bear with me. Imagine you're really, really hungry, so you decide that you're going to cook yourself some food on your stove. You have all the ingredients that you need. You know how to cook the thing that you want to make. But when you gather all the ingredients and you go in front of your stove, you notice something. There's no button to turn on the stove. It no longer matters that you want to cook food. It doesn't matter that you have all the ingredients. It doesn't matter that you're really, really hungry and you know how to make the thing. If there's no button on the stove, you can't turn it on. You can't cook it. And that's kind of how it is with executive dysfunction. It doesn't matter how motivated you are to do the thing. Sometimes your brain just removes that option. It has nothing to do with motivation, willpower, skill. If your brain removes the option, there's nothing you can do.
What is one thing that you do?
And there's looping TikTok. It's a complicated thing, and I've had the hardest time throughout my life trying to explain this, but it's something I've been struggling with a lot personally. I have things I want to do, and I just can't get the spoons together to actually do them. And I feel very stuck in my own brain, and it feels terrible. It's hard not to beat myself up about it. But it's hopefully something I'll be able to manage and deal with in the future, but God, it's hard. Well, that's the end of this lecture. Like I said, this is a personal topic, I think, for many people. It's a personal topic for me. Like I said, I've lost friends to suicide. I don't often talk about it, but I have, lifelong issues with anxiety and depression, and it sucks. It's kind of what it is. So it makes it a weird lecture to give, because I'm both giving these kind of very clinical examples, but at the same time also having very personal anecdotes in relations to things. So it's weird. So I got a lot of thoughts going on in my brain, having gone over that. I hope this was good. I hope you enjoyed this. I hope you learned something. I feel like this is, again, like a hard thing to for some people to deal with, one because of the personal example, like the personal relevance for many people, but also the fact that there's so much misinformation that floats around about all this stuff that it's hard to crack through it and tease out what is myth and what is real. So hopefully I helped about with this. And we have 1 week left of this. We're going to be talking about treatments. We're going to be talking about therapy. We're going to talk about the history of therapy. We're going to talk about what kinds of therapies work best. We're going to talk about, like telehealth and teletherapy. Is that actually a thing that could potentially work for people? Let's talk about it. So I will probably be sticking around for a bit in office hours, but if you need to take off, that's cool. If you're watching the video on YouTube, that's also very cool. I hope you learned something, maybe had a laugh or two, and let's hang out again sometime. Take care. Whoop!